Thank you for inviting me. My topic for today is how to approach sedation in a patient with liver disease. And let us see why liver disease demand a separate special consideration, and that is because a lot of these drugs, or most of these drugs, have their main metabolism in liver. Liver is also involved in protein synthesis and therefore binding of drug and metabolites. A lot of chronic liver disease, and for that matter acute liver disease as well, will have alterations of liver blood flow, so will have impact on first pass metabolism, and portosystemic shunting as well will affect that. In addition, there is increased neurosensitivity of these drugs, and in liver disease, pre-existing hepatic NCAF, and a lot of patients will have renal impairment, which will impact the clearance mechanism as well. So what is an ideal sedative to be used in liver disease? One which is having a rapid and predictable dose response, a short duration of action, doesn't remain in the body and is cleared with liver not being involved in the metabolism, and it is not affected by kidney function. It should have a wide safety margin and a good reversing agent. Now, this is a utopia, and most of the agents that we use do not fulfill these criteria. Now we shift to the patient perspective of this, and this is one of the studies that we were involved in. It's a Tamil Nadu-wide Indian Society of Gastroenterology study, and we looked at all the toxic hepatitis in 6 districts across Tamil Nadu for a period of January to June 2019. So we found that rodenticide is one of our most common cause of toxic hepatitis, and we had 450 patients of this disease from January to June 2019. Now, out of these 450, 35% patients had died due to the acute liver failure. But if you put in perspective, urgent liver transplantation was only done in one patient. So out of 160 patients who died during this time period, only one underwent liver transplantation. So if we extrapolate this data, we would have 1,108 patients over a period of 1 year with rodenticidal hepatotoxicity and liver failure deaths. But during that time, the cadaver transplant listing for supra-urgent liver transplants in Tamil Nadu was only 3. So urgent liver transplant really is not a reality in most of our patients with acute liver failure. And the question that we ask then is, when urgent liver transplant is not possible, why to sedate? Now, most of the guidelines that we follow is from the West, where urgent liver transplant is available, and the guideline says a high proportion may be requiring sedation for transfer. So we are asking, why sedate? Now, we understand that there are many reasons why a person will require sedation in acute liver injury. Most often than not, it is the consideration of reducing cerebral edema, that is to calm down an agitated patient. Otherwise, there will be indications to sedate as well. Now, why is sedation such risky in patients with liver injury? And first reason may be because a lot of these sedative drugs are metabolized in the liver. Now, liver is the central processing unit for most drugs, and most drugs are either oxidized, undergoes oxidation reduction or hydrolysis. Some of them directly undergo conjugation. So most of these drugs will undergo some sort of biotransformation in the liver, and the choice of the pathway may also be influenced by the liver disease process. Various factors influence the liver disease clearance of these drugs, and this can be because of liver disease affecting the metabolizing capacity of the liver. So conjugation is preserved till a late liver disease effect, till a late liver severity, and whereas liver blood flow and protein binding also is directly affecting hepatic clearance. Now, portosystemic shunting, as I mentioned, will affect orally administered drugs metabolism and first pass metabolism in the liver. Now, we understand that most sedatives and hypnotics that we currently use are metabolized in the liver. and then eliminated by kidneys. Now, in liver disease, lot of patients will have kidney dysfunction as well. So that part is also getting affected. Liver, as we know, is the factory of the body, and the largest amount of biotransforming enzymes are present in the liver. So if we say individual drugs, we can look at it in any way. Pethidine, fentanyl, most of the benzodiazepines actually are metabolized by oxidation pathway in the liver and then undergo conjugation. Lorazepam and oxazepam are generally conjugated in the liver, and therefore the metabolism is less affected by the liver disease severity, and maybe the preferred choice in this group of patients. Propofol for a planned anesthetic short anesthesia is something that can be used, but it doesn't come without its own problem of it causing deeper sedation. Secondly, it is rapidly redistributed to muscles, which a person with chronic liver disease having a muscle loss will be a problem. And thirdly, the fact that anesthetist is required for propofol administration is always is difficult. Now, one of the medications that we commonly use in ICU setting is Dexmed, which is used for sedation for adults in hospital ICUs. And warning is definitely a severe liver problem is still a warning for use of Dexmed as well. And its clearance decreases with severity of hepatic impairment, and dose reduction is warranted in most patients. Now, this is also renally eliminated, and that also may be an issue with use of Dexmed in liver function dysfunction. The second point to consider is benzodiazepine receptors in CNS may be always involved in hepatic NCAF. Now, what we know is from previous studies that flumazenil, which is a GABA receptor antagonist that reverses the use of benzodiazepines, it has been used as a non-specific agent in patients with hepatic encephalopathy. Now, the Cochrane database review on this suggests that flumazenil has a short-term beneficial effect on hepatic NCAF, suggesting that the receptors involved in encephalopathy may be similar to what benzodiazepine uses it for its function. Now, this is the receptor, and we can see that GABA, the primary inhibitor neurotransmitter of CNS, and the benzodiazepine receptors are all similarly located, and this is the primary action of all these sedatives. So to say this, that in patients with liver disease, the cerebral sensitivity is also altered. Now, even though the pharmacokinetics of the drugs, sedative drugs, is definitely altered, as we have already discussed, most of these drugs are disposed of by the liver, and they are definitely because of the changes because of the liver disease, there will be a prolonged exposure to these drugs, and prolonged exposure to increased levels of these drugs in the blood is very common. Even if we do adjust for the dosage, the sensitivity of these drugs itself at the cerebral level will be altered. So even if we discount the pharmacokinetics, we still require dosage reduction for all these drugs, and dosage what studies have suggested is up to 1/3 to 2/3 of doses what we use in normal population is what may be enough for use in these difficult to treat patient groups. Now, based on all this, we can divide various properties of these drugs. So these are the commonly used drugs that we have: diazepam, lorazepam, pethidine, that we commonly used as sedative narcotics in patient groups. And we can see that all of these drugs will have some problem or the other, either it being a pharmacokinetic effect of elimination by liver disease or by liver, or protein binding which is affected by liver disease, or it could be an enhanced effect on the receptor which will preclude use for all these drugs. If I have to see these drugs, I would think oxazepam or lorazepam may be the drug which can be used at a lower dose, in some of these patients, but all these drugs do come with problems which are inherent due to an underlying liver disease, may it be an acute or a chronic liver disease. What we also need to understand that if a person has altered sensorium in an acute liver injury, a lot of these may be hepatic NCAF and some of it will be attributable to cerebral edema. There may be various other causes and which need to be targeted and which need to be dealt with separately, and we will have to deal with hyponatremia, and sedative drugs per se can cause altered sensorium in these patients. Now, say sepsis or any other disease which I have listed here can all contribute to altered sensorium in these patients and need to be targeted. And we need not attribute everything to cerebral edema and start giving sedative drugs for that. The cost of sedation can be very high in these patients with acute liver injury. So suppose a person comes with the acute liver injury to a casualty and a person has altered liver function with an INR of say more than 10, but he is conscious and slightly agitated. Now, if I give a sedation to this person, he is more likely going to have a prolonged exposure to high doses of drugs in the blood. And this will be, when a second person sees this patient, it will be labeled as encephalopathy. Now, if it is encephalopathy to a certain grade and the Glasgow Coma Scale will help us guide that, we will need mechanical ventilation for airway protection, and this person will then be listed for liver transplant, which we have already mentioned is not a option for majority of our patients clinically, which we see in our practice. So what we are basically doing is pushing a person down very fast towards transplant, which is not often the case in these patients. And we know mechanical ventilation in a sick patient is fraught with danger per se. So coming back to the indications for transplant in acute for sedation in acute liver injury, these are the indications commonly we sort of encounter in our patient, and we think for endotracheal intubation we may have to use sedation, but we will have to consciously use the least amount of sedation that is required, and at a very monitored setting. Same for mechanical ventilation, but for a softer indication like an agitated patient, or for a procedure which is nasogastric tube or a central venous line, or for that matter even intra-hospital transfer, if we can avoid sedation, we should try and avoid sedation. So really one line message for the whole presentation would be to avoid sedation if possible in a patient with severe acute liver dysfunction. We also understand that this patient with acute liver injury may not directly come to a specialty or a higher center, and would have gone through various other levels of care before actually coming to a higher center for, or an intensivist or a gastroenterologist or a hepatologist for that matter. And there is a chances of this person receiving sedation at various levels of contact, and we have to keep that in mind before labeling it as hepatic NCAF and going towards the transplant route. And we should look at sedation as possible cofactor as well. Now, if I look at the hepatotoxicity of a rat killer, for instance, because rodenticide is one of a common indication for liver injury and liver failure for us. Now, if the person has liver functions which is normal, now more likely this person won't require sedation, but the risk of sedation itself will be low. But if the person starts to get prolonged INR, that is the synthetic function is getting prolonged, that is in patient with acute liver injury, that is where we start getting more problems with the sedation. There is more respiratory depression, drowsiness. This patient may go downhill towards mechanical ventilation and transplant. And this is more exaggerated as the liver injury tends to progress. So to summarize, one is we should always understand there is a big potential of harm for use for sedatives with any patient with acute or chronic liver injury, and that has to be recognized at all levels. We understand that sedation may be required in some of these patients, but to an extent possible, avoid sedation, and if not possible, institute strict check mechanisms for use of sedation that may be at a higher clearance at a higher level to be instituted for use of sedation in these patients. If still it is deemed essential, we would suggest use minimal dosage with gradual escalation in carefully monitored setting. Now, all these recommendations may be a slight variation from what is recommended in the West, because the guidelines are more concentrating on acute liver failure and decrease of cerebral edema. What we are saying, and where the transplant is available, but what we are saying is we will have to maximize the patient outcome without or before transplant. So we wouldn't want to push the patient down to mechanical ventilation. So we would say avoid sedation as much as possible in this patient group of liver injury. Thank you.